So now to proceed and to welcome Professor Martin Schaller, speaking from the office at the Department of Dermatology, Venereology, Allergology in Tübingen University. Welcome. Good evening, Professor Schaller.
Yes,
we are going to talk now about rosacea, and we are looking forward now to listen to you about the second important topic of tonight. Welcome, and the arena is free for you.
Thank you very much for these nice words, and good evening to Israel from Germany. So I will talk about rosacea, and this is a very important topic, and for me, Soolandra is really a new milestone in rosacea management. Here you can see the inflammatory pathways in rosacea. And what is shown also in vivo and in vitro is that a catalyzing activation pathway of the keratinocytes is important, but also the inflammasome activation pathway of the macrophages. And here you can see a lot of key player of inflammation, for example, L37 or interleukin-1 beta, and at the end of this cascade, there's interleukin-8 and TNF, and leading to all the symptoms our rosacea patients are suffering: inflammation, pain, and neutrophil recruitment. So important is one question: has Demodex a role in rosacea? And today we know that there's a higher density of Demodex mites in rosacea, and this has been shown by several methods, by PCR, by confocal laser microscopy, but also by skin surface biopsy. And it's a theory that these Demodex mites may cause an immunological reaction in rosacea patients, or they might exacerbate the barrier disruption. So this is one of the important papers showing that Demodex is more common in rosacea patients. They included 18 patients with erythema and telangiectasia, but also with patients with PPR, papillopustular rosacea, and they made a non-invasive samples for the evaluation of the Demodex density and the inflammatory immunological markers. And as you can see here, Demodex was found in 96% of the rosacea patients, but only in 75% of the control patients. And there was a six-fold increase in Demodex density in rosacea skin as compared to normal skin. And also there was a lot of inflammation in these patients and an upregulation of this inflammatory markers I mentioned before: interleukin-1, TNF, cathelicidin, and interleukin-8. So it makes sense to have a medication with a dual mode of action, which kills Demodex and works against the inflammation. And the ivermectin is a good example for such a medication. It's a macrolide. It's isolated from Streptomyces, and it has both anti-inflammatory and anti-parasitic effects. It's approved for the treatment of worms and ectoparasites, and in Germany also for scabious mites. But in Germany, it's also since years approved for the treatment of papules and pustules and rosacea. And there are a lot of case reports about the improvement of rosacea under oral ivermectin and Permethrin therapy. So I wanted to show you some pivotal studies about ivermectin in rosacea, and that this was the US study, which was published 5 years ago, and they included a lot of patients, almost 700 patients in the study 1 and 700 patients in study 2. And the FDA, for the FDA, it's important to have 2 identical phase 3 pivotal studies. Patients were included with severe or moderate rosacea, with more than 15 and less than 70 papules and pustules, and the endpoints were the EGA of clear or almost clear in week 12 and the change in inflammatory lesion counts. And I want you to show here the concept of this study. There was a 2-to-1 randomization, 2 arms, ivermectin versus the vehicle. Again, the investigator global assessment scale, and you can see that this was the aim of the study. Success was defined as clear or almost clear, and included were patients with moderate or severe rosacea. And here is the mean percentage change in inflammatory lesion count, and you can see at week 12 there was a minus 76% reduction of inflammatory lesions by ivermectin and 50% by the vehicle, and this was significant difference not only at week 12 but also beginning at week 2, 4, and 8. Here are the results of the patients reaching clear or almost clear, and at week 12 almost 40% of all patients reached the aim clear or almost clear. So it's a very effective treatment. And you can see a patient of Tübingen which improved within 4 weeks with this moderate or severe rosacea by the use of ivermectin cream. It's also a very safe treatment. Here you can see the adverse events: burning, irritation, dry, pruritus, or pain. And when you compare the percentage between ivermectin and the vehicle, you can see that the percentage of ivermectin was in all cases lower than of the vehicle, probably because of the anti-inflammatory effect of ivermectin. So it's a very safe and effective treatment of rosacea. There was also a 40-week extension study with ivermectin. So this was the part A we just talked about, and patients which were treated with ivermectin cream, they extended the ivermectin therapy for 40 weeks. So they have almost 1 year treatment with ivermectin. The patients who had the vehicle cream, they were changed to azelaic acid. So you cannot compare these 2 arms, ivermectin and azelaic acid, but what you can see is that these are the blue one, the patients reaching clear or almost clear, and depending on the length of the treatment, there was a forward-going improvement of the skin of this rosacea patients, and the patients reaching clear and almost clear were increasing depending on the length of the treatment. So it's a long-term therapy, and it is also very important to have this long-term therapy for our rosacea patients. You can see one patient also from Tübingen. At baseline, after 3 months, he was almost clear, but he needed 8 months to be complete clear. And often it's very important to discuss this with your patients, that as in acne, as mentioned by Professor Gollnick, there is no quick response for this disease, for acne, or not for rosacea. In Europe, there was another study, a pivotal study. In Europe, you have to test the treatment not against vehicle, but against the gold standard. And the gold standard before ivermectin was metronidazole. So there were in Europe a phase 3 study with more than 900 patients, and one part used ivermectin cream and the other part used metronidazole 0.75 Gel. Inclusion criteria were similar to the US studies, EGA of 3 or 4, that means moderate or severe rosacea, and more than 50 and less than 70 papules. Ivermectin cream has the advantage that it has to be used only once daily. Metronidazole in Germany is recommended twice daily. And also the endpoints were the same, EGA of clear or almost clear, but it was a 4-month study, and the change of the inflammatory lesion. And this is the period A I want to talk about now. And here you can see also the mean percentage change in inflammatory lesion count as you saw from the US study. And after at week 16, that means after 4 months, there was a minus 83% reduction of inflammatory lesions. And also metronidazole was very effective in the study with minus 74%. Study was very reproducible. If you remember the week 12 results of the US studies, here at the European studies, it was minus 76, and in the US, it was also minus 76. So in the US and in the European study, if you look at the same time point, week 12, there are very comparable results of this ivermectin cream. The EGA score was even better, reaching 84% patients with clear or almost clear at week 16 for ivermectin and 10% less patients for metronidazole. So both are very effective treatments. The difference between these both treatments were 10%. If you see all the patients with moderate and severe rosacea mixed, but if you look only at the severe rosacea patients, the difference was larger. There was a 20% difference. That means that ivermectin has also a benefit for patients with severe rosacea, a better benefit as metronidazole. There was also a part B of this rosacea study, and the part B were included subjects who were clear or almost clear at the end of part A, and they were within the study for a 36 weeks follow-up. And the aim of this period B was to find out if the time for the first relapse would be different between metro or ivermectin treated patients. So all these patients have been clear or almost clear, treatment was stopped, they were controlled every 4 weeks, and in this study it was the aim to look when was the relapse. Is there a difference in the time-free relapse between ivermectin cream or metronidazole cream? The cutoff was the time point when a relapse was seen in 50% of the patients. And here you can see this cutoff, and you can see in blue the patients which were treated with metronidazole, in red with ivermectin, and the cross of this line, the blue line or the red line, is the time point when there was a 50% relapse of the patient. And we can say this cross was reached by metronidazole after 84 days, but with ivermectin 30 days later. So there was a 1 month longer relapse-free interval with ivermectin. So my conclusion, my first conclusion is that it's a superiority of ivermectin cream. It's significantly better than the vehicle in the US study and the metronidazole cream in the European study. Concerning the success rate, the change from baseline in inflammatory lesion count, and what I showed not before in the improvement of the quality, of the life quality of the patients. The treatment had no effect on telangiectasia, but it had an increasing benefit during the long-term use, and the time to relapse was significantly longer for ivermectin. And ivermectin was excellent tolerated and safe in this treatment. Another very important question is, how long should we treat our patients? And my aim is that the patients should not stop treatment when they are almost clear, but they should continue the treatment until they are completely clear. Even if it needs a lot of time to reach this clear status. So as always in skin treatment, you have a rapid improvement after 6 weeks, but you need a lot of more weeks to get completely clear. For example, also this patient, he was first treated in a study, in the ANSWER study, with ivermectin cream. This was a 12-week study, and he had a really severe papulopustular rosacea, and he was almost clear after 12 weeks, but he needed 10 weeks more or 9 weeks more to be completely clear. But the question is, we reached this with a combination of ivermectin cream and doxycycline modified release. But the question is there a difference for the patients between almost clear or clear? And this was a re-evaluation of different studies. And as a result of these studies, it was found out that there is a difference. In the original study, this difference between almost clear and clear was not analyzed, but it was analyzed in this study published 2017 by Jared Webster, and you can see patients clear had a better improvement of their life quality versus patients which were only almost clear. If you are measuring the life quality, you use the DLQI, and a DLQI of 0 of 1 means that this disease does not affect my life. And only 66% of the patients which were almost clear said they have a DLQI of 0 or 1, but 84% of patients which were completely clear. That means to reach clear has a clinical impact. And also clear provides a longer time to relapse. And there was at least 5 months difference in time to relapse in favor of clear versus almost clear. And again, you can see this cutoff, and in red you can see all the patients who were treated until they were almost clear, and in blue, these were the patients who were completely clear. And again, after 84 days, this red line crossed the cutoff line, but the blue one, as patients who were completely clear, never reached this cutoff within the follow-up interval. So at least a 5-month difference in time to relapse. So the conclusion of this study is clear should be the goal of our treatment because it provides a better outcome. It's clear, it's a better improvement of rosacea, but also a better improvement of quality of life, and at least 5 months later, longer time to relapse. Coming back to our inflammatory pathway in rosacea, and all these things you can see here, the inflammasome and the cathelicidin story. This has been shown in several papers in vivo and in vitro, but what is not so clear is if Demodex is really the actuator of all this inflammation and of all these inflammatory pathways. The problem of Demodex mites is that you cannot cultivate these mites. So it's not possible to make in vitro studies with these Demodex mites. So we used a different approach to bring something more clearness in this question. So we included patients with rosacea with this upregulation of all these inflammatory markers, and then we measured these markers and treated the Demodex mites, and we compared the inflammatory markers before and after treatment. So we used ivermectin to treat our patients. And here you can see a typical analysis of the Demodex density. You can see a lot of Demodex mites, families of Demodex mites consisting of 5 or 10 members within the hair follicles of the patients with rosacea. And we included 20 patients and looked at the Demodex density at baseline, week 0, and this was a mean Demodex density of almost 100 mites per square centimeter. And after 6 weeks, this was a rapid and a large decrease of this Demodex mites from 100 to 4, and after 12 weeks, there were almost no Demodex mites visible. So we were also interested how quick this decrease of Demodex mites would happen. So we had some patients which we did every day an analysis of the Demodex density by this skin biopsy with a glue. And you can see after 1 week, there was a decrease, a significant decrease of Demodex mites. After 1 week, there were no Demodex mites seen in our analysis. So it's very quick. And as mentioned before, we did also these inflammatory markers, and you can see this is week 0, week 6, week 12 for TNF, for HBD3, 37, TLR4, and interleukin 8. And for all the first 4 markers, we see significant downregulation of this inflammation in our experiments, also for interleukin 8, but it was not significant. So my second conclusion is that ivermectin has a dual anti-inflammatory and acaricicidal effect. We could show a significant downregulation of pro-inflammatory immune regulators, IL-37, TNF, TLR4, and HBD3, and a significant decrease of Demodex density even after 1 week. There was a positive correlation between the Demodex density and the treatment rate. That means if you have a patient with a high Demodex density, the rosacea improved more as compared to patients with a low Demodex density. And interesting, in moderate rosacea, there were a higher Demodex density as compared in severe rosacea. Coming back to another topic, to the Rosacea Consensus Project. This was an expert panel, which was the first time in February 2016 in a meeting in Miami, and there was most recently an update of this Rosacea Consensus Project. And all the studies began in 2017 by this paper of Jerry Tan and co-workers. And in this paper published in the British Journal of Dermatology, he discussed shortcomings in rosacea diagnosis and classification. And what he did was that he critically discussed the diagnostic criteria of rosacea, which were published in 2002 by Jonathan Wilkin and his group as a report of the National Rosacea Society Expert Committee. So they defined primary and secondary criteria of rosacea, and primary criteria was defined, you need only 1 or more to have the diagnosis of rosacea. And if we look at this criteria, that makes no sense. So papules and pustules is a primary criteria. That means every patient with papules and pustules has rosacea, but Professor Gollnick would not have this opinion because papules and pustules is also a sign of acne. So this makes no sense. Also not telangiectasia, because telangiectasia is also a sign of sun damage. And they defined also secondary criteria, and there you need 2 or more to be to have This is not right. You need 2 or more to have the diagnosis. And for me, phymatous changes is a primary criteria. So if you have a patient with phymatous changes, what else should this be instead of rosacea? So another critical point were the subtypes. This is the rosacea classification, subtype classification, which is the best known and the most famous rosacea classification. And in this classification, they defined the EGR subtype, the PPR subtype, and the phymatous subtype, and ocular rosacea. But this classification did not reflect the clinical situation. So if you look at your patient in your practice, you have some patients which have only EGRs, for example, this patient with erythema and telangiectasia, or you have some patients with only PPR, papules and pustules, but the majority of patients have an overlap of different subtypes. So this patient has erythema, papules and pustules, and this patient has erythema, papules and pustules, and ocular rosacea. So this makes no sense to have this strict classification of EGR, PPR, and so on, because the patient often present with a range of signs and symptoms. And it makes also no sense to use this EGR, PPR classification for treatment recommendation. I want to give you some example, because if you have a patient with EGR, it could be a patient with telangiectasia, and this patient you can only treat with laser treatment, or it could also be a patient with erythema, and you can use also a topical treatment to help this patient, for example, with brimonidine. So it makes more sense to define different features of the patients as a base of the treatment. And we did this in this expert meeting with members from Africa, Asia, Europe, North and South America. You can see from all of the world, the experts were coming to Miami for this meeting. You can see here the expert panel and 2 chairs of this expert panel. And the results of this meeting were published in 2017 in the British Journal of Dermatology. One paper was the updating diagnosis and classification. And what we did first, we redefined the diagnostic, the major and the features of rosacea. And in this panel, we had the consensus that there are some features that are considered individually diagnostic. So if you have, as mentioned before, you have a patient with phymatous changes, this is clear, this is rosacea. But we also defined the persistent centrofacial erythema as an individually diagnostic feature, but only this one, which is in the central facial location of the face and which is associated with periodic intensification by the trigger factors. There were some other features which were diagnostic only in combination, that you need 2 of them, inflammatory lesion and telangiectasia, for example. And there were secondary features which are well known in our rosacea patients, burning, stinging, but they are not diagnostic. So the next was that we defined these features of rosacea as a base for treatment recommendation. And this was also published in the British Journal in the same year, and was updated most recently 2019. I want to present this updated version, this updated treatment algorithm based on the features. And you can see the features of rosacea, which we discussed before: transient erythema, persistent erythema, inflammatory papules, pustules, telangiectasia, phyma, and so on. And you can also see that these features are divided in mild, moderate, and severe. And then you can see all these treatment options which are approved in the different countries for the treatment. General skincare is very important for all these features. But if you want to treat inflammatory papules and pustules, you have the choice between azelaic acid, ivermectin, or metronidazole. And as shown before, ivermectin makes also sense for the treatment of severe rosacea. You have the beta blockers with the transient erythema, and doxycycline and the isotretinoin. So this is a very good tool for the choice of treatment of all these features of rosacea. So one of these patients with a very severe rosacea, which I showed you before, and I want to show you something new which we doing in Tübingen in the last years, because this patient, I asked him to use ivermectin cream for the skin, and he asked me, what should I do with my eyes? And if you look at his eyes, you can see that he has also a blepharitis, and he has some papules and pustules here on the lid edges, and he has telangiectasia. And I asked him to use also the ivermectin to close his eyes and use the ivermectin on the eyelids, and very carefully at the lid edges, and he improved with his ocular rosacea. Here you can see after 3 months, strong improvement of this papules and pustules of this blepharitis, and it was completely clear of his ocular rosacea after 7 months. So we decided to begin a little study with topical ivermectin therapy of ocular rosacea, and at the moment we have 10 patients which were treated with ivermectin, and we included patients only with mild or moderate ocular rosacea, so with signs of blepharitis, chalasia. Typical symptoms of ocular rosacea are foreign body sensation, dry eye, light sensitivity. And the treatment was with this ivermectin cream once daily. And we have a really good results, a strong improvement of patients. And at the moment, this paper is submitted to an ocular journal. I can show you also another patient which was treated with ivermectin cream, here with chalasia. And there's often are patients which are suffering from chalasia several times. Every 3 months they are suffering from a big chalasia, and you can see the strong improvement of this chalasia after 3 months ivermectin cream therapy. So I think this is a good treatment option. It's off-label, that is clear, but it helps our patient to improve with her ocular rosacea and to prevent systemic treatment. Another very interesting result of ivermectin I want to show you in this study. This is a result of this so-called ANSWER study of rosacea treatment. And in this ANSWER study, there were 2 arms. Half of the patients were treated with ivermectin and doxycycline modified release 40 milligram, and the other part of the patients were treated only with ivermectin and vehicle. So the interesting was that both treatments showed a reduction of the erythema, and the patients becoming clear of erythema were increasing depending on the length of the treatment, also in both treatment arms. That is interesting, because if you look at our medication, ivermectin and doxycycline, this is approved for the treatment of inflammatory papules and pustules, but not of the treatment of erythema. But erythema strongly improved under this treatment. So normally, if you have erythema, here also patients from Tübingen, you would treat them with brimonidine or oxymetazoline, which is also approved in the US. So a typical brimonidine patient, and here you can see after 3 hours, you can see this over whitening, which is sometimes a problem with our rosacea patients. And this is a treatment with brimonidine gel, but there are some patients, for example, this one, also with erythema, they improve with ivermectin cream. And what is the difference between this patient, why this patient responds to brimonidine and this patient's response to ivermectin? And it looks similar. They are both patients with erythema, but they are very different if we take a closer look to the skin texture. So I want to show you the skin texture of this patient, which improved by brimonidine. We can see a lot of these vessels of telangiectasia, and as compared to this signs, there's a very different skin texture in the other patients. They are not so many telangiectasia, but this patient has a rough skin. He has a grainy skin, and if you have some superficial pustules, but he has also some spikes here. You can see this in your patient. If you take a closer look, you don't need a magnification, but you can see the spikes coming out of the follicles. And this patient have a lot of Demodex mites. And here you can see the Demodex analysis of this patient with a lot of Demodex mites. Here again the families, and here the Demodex mites in a larger magnification. And here another example of such a patient with a lot of Demodex mites. I call this an inflammatory erythema. And here again, often these patients have ocular disease. They have this inflammation also of the lid edges, and you take the closer look, you can see both in this female patient. You can see the spikes here, and you can see the grainy skin texture, the rough skin texture, and see there are more than 370 Demodex mites per square centimeter. And this patient strongly improves by ivermectin cream. And again, the eye of such a patient, it's very typical. Patient with this grainy skin texture, with this rough skin texture, they have often ocular rosacea. You can see the conjunctivitis, you can see the thickening of the lid edges, you can also see the telangiectasia here and also here. And what is very typical is the cylindric scales around the lashes, which is very typical for Demodex blepharitis. And this patient strongly improved with ivermectin. I call this inflammatory persistent erythema. This is not my theory. This was described before by Iris as pityriasis folliculorum, clinically fine whitish keratotic spikes and irregular rough skin with a high Demodex density. And the patient have all the signs which are very typical for our rosacea patients. They have flushing, they have burning, stinging, itchy, dry skin, and they all have a blepharitis. So you will clearly diagnose this as erythema of rosacea. But this patient will improve better by ivermectin than by brimonidine. So I think we have to make some amendment for this clinical features of rosacea. The persistent erythema can be mainly induced by vasodilatation, and it can mainly induced by inflammation. And vasodilatation is improved by brimonidine and inflammation by ivermectin. And I can show you some patients with a good improvement. For example, you saw this patient before and after 6 weeks ivermectin. Here, an older patient with inflammatory erythema after 4 months ivermectin, and again our lady also good improvement after 4 months ivermectin. Coming back to the care of the redness, and this is very important. If you look at the treatment algorithm, the general skin care is very important in all the features of rosacea. And coming back to this study, what is sometimes interesting that the vehicle has a really good effect also in the study. The ivermectin is better than the vehicle, but you have a minus 50% reduction of inflammatory lesion. And the reason for this good effect of the vehicle is that in this study, Cetaphil vehicle was used. And there are 3 levels of evidence for the improvement of rosacea, redness, brown skin. And the efficacy of the Cetaphil pro-redness control has assessed by 3 evidence levels that combine clinical and instrumental measure outcomes: clinical improvement, instrumental evidence, and patient-reported outcomes. So one of the first things which is improved by the control wash lotion is the amount of the superficial sebum, and only a one-time treatment reduces the superficial sebum by almost 90%. So this is a very impressive improvement of the sebum of the patients, which is also might be a factor in rosacea, not only in acne. Cetaphil also moisturizing cream also reduces the redness in only 3 days. So there were significantly lower values of skin redness or erythema after 3 days after application of this moisturizing cream as compared to baseline. You can see here the values at baseline: 3 days, 8 days, and 3 weeks. And this was a significantly decrease of skin redness, but also the barrier was improved. And this is very important for our rosacea patient because it's well known that this rosacea patient have a disrupted skin barrier. And therefore, the moisturizing cream is so important and showed a decrease in the transepidermal water loss 24 hours later as compared to the control. It strengthens the skin barrier, and the intensity of redness decreases significantly following 3 weeks of once daily treatment. So, as a summary, the skin redness is reduced by the control night moisturizing cream, and you can see this in this patient before and after a 3 weeks treatment with this redness control moisturizing creams. Thank you very much for your attention. And I'm happy to have some questions. That would be very nice.